This presentation is on Gonstead Case Management. It has quite the broad spectrum of case management through the Gonstead system, but in this presentation we're just going to focus on a few areas of Gonstead Case Management, cases that you will typically see in your clinic. Question: do you feel you are taught an adequate amount of chiropractic case management during your chiropractic education? You can answer yes or no, and I'll cover this in the lecture presentation live and get some feedback. What area of case management do you feel would be the most helpful to learn? Take a minute, answer this question, and we'll have discussion on it in the live session. Gonstead Case Management. The Gonstead Case Management notes were created from doctors who attended Gonstead seminars and heard Gonstead's clinical experience on many different types of cases. These notes were compiled over decades of Gonstead seminars and were compiled by these doctors. These case notes are not considered a cookbook on how to approach and manage chiropractic cases, although it's a valuable guide to help you navigate a variety of cases with the Gonstead system of chiropractic. It definitely is a good place to start on your approach to a particular type of case, and more often than not, the Gonstead notes are very, very accurate in managing the types of cases that are mentioned in the book. This presentation, again, will just focus on a few different types of cases. Quote by Gonstead: chiropractic always works. When it seems as though it is not working, question the application, not the principle. When Gonstead was taking care of cases that were beyond just the musculoskeletal or neuromusculoskeletal presentations, when they had visceral concomitants, Gonstead used some criteria to divide the spine or nervous system up into how he would adjust the patient. In his 55 years of practice, he developed a system that divided the spine up into parasympathetic and sympathetic nervous system. And you're going to say, yes, well, we already know there's two parts to the autonomic nervous system. But what he did is he divided up the spine or spinal segments or nerve roots into areas that had a parasympathetic or sympathetic effect on the patient when he adjusted them. He said that the sympathetic response came from adjusting segments C6 to L5, and that the parasympathetic response came from occiput through C5 adjustments, sacral segments, and ilium. And what he would do is he would adjust just only one segment per visit when dealing with these patients with this visceral concomitant. He would only stay within one system when he did adjust. He would only adjust sympathetic or parasympathetic on a particular visit, would not adjust more than one segment, and he would stay within that system, meaning sympathetic or parasympathetic, until the patient saw resolution to the problem. He found that he got his best results one adjustment at a time or one segment at a time. It's always I'll start that again. It's important to remember that no segment is ever adjusted unless it has all of the Gonstead criteria for adjusting a subluxation. Your scope reading, decreased range of motion. We just don't adjust the patient according to the case management notes. We have to find the subluxation on the patient, accept it where we find it, correct it, and leave it alone. And the Gonstead Case Management book notes are not meant to be like a Merrick chart where you have a particular issue with the organ and you adjust a certain vertebral segment or nerve root. It's a guide to get you started in caring for your patient. One of the areas of the case management I want to focus on today is female reproductive system and hormone issues. The problems in this system tend to be due to one of three things: a structural problem, a functional problem, or a medical cause. If the patient presents with both a structural and a functional problem together, we correct the structural one first. We're going to focus on particularly pregnancy and miscarriage for the female. The common areas of subluxation with these problems are in the C6 to T3 area. This is a sympathetic area, and has typically to do with the functional component of an organ system. In particular, this area affects the thyroid function that's vitally important to the pregnant mother and the fetus. And we'll get into this a little more in a minute. And more of the structure under that is down near the pelvis, the lower lumbar and pelvis area, and these are parasympathetic input. And this is more of the structural component around the lower part of the body, the spine, and the pelvis. This neurological innervation goes directly to the uterus. The structural misalignment may affect the ligament support of the reproductive organs. The reason I wanted to focus on the women's pregnancy and difficulties with pregnancy and miscarriage is because I've seen this quite frequently in practice. And it often has to do with the role of the thyroid hormones and what role they play in the pregnancy. The thyroid hormones are crucial for the proper development of the baby's brain and nervous system. During the first trimester, the first 3 months of pregnancy, the baby depends on the supply of the mother for the thyroid hormone, which comes through the placenta, and there's a link there to the National Institute of Health. Around 12 weeks, the baby's thyroid starts to work on its own, but it does not make enough thyroid hormone until about 18 to 20 weeks of pregnancy. Two pregnancy-related hormones, human chorionic gonadotropin and estrogen, cause higher measured thyroid hormone levels in your blood. The thyroid enlarges slightly in a healthy woman during pregnancy, but usually not enough for the healthcare professional to feel during a physical examination. Thyroid problems are difficult to diagnose during pregnancy due to the high levels of thyroid hormone and other symptoms that may occur both in pregnancy and in thyroid disorders. Some symptoms of hyperthyroidism or hypothyroidism are easier to spot and it may prompt the doctor to test these thyroid diseases. How can hypothyroidism affect the mom and baby? Untreated hypothyroidism during pregnancy can lead to a variety of hormonal and complications for the pregnant mom. Preeclampsia, a dangerous rise in the blood pressure late in pregnancy. Anemia, miscarriage, low birth weight, or stillborn. I've seen a lot of the hypothyroidism affect the mom and the baby, leading commonly to a miscarriage. I've seen this a few times in my practice. Once the moms began chiropractic care and were able to control the subluxation and nerve pressure around the thyroid, they did much better and were able to maintain pregnancies without any other assistance. I did have one patient that went to a clinical nutritionist, and she had some nutritional counseling to help support the thyroid through supplementation and some formulas that were made for her, and she did very well after miscarrying 3 times in her second pregnancy. Once she started chiropractic care and received some supplemental support for her thyroid, she was able to conceive and maintain a healthy pregnancy. It's a picture of the nervous system with the autonomic plexuses in the lower parasympathetic area of the spine. Again, I put these in here because it shows you how complex the neurological input to the pelvis is, with many plexuses coming together, kind of like our brachial plexus, where a lot of the nerves will cross over into other nerves and go into the ganglion, and it is a very complex area down there. That's why maintaining proper nervous system function, both through the nervous system in the pelvis as well as the mechanical integrity of the pelvis during pregnancy, is very important. Here's a list of some common female problems that you'll often see in your office. We'll list the problem, whether it's a structural or functional issue, and the area of the spine that's commonly associated with difficulties in these areas, the levels of subluxation. Frequent periods is a parasympathetic issue, typically functional. Irregular menses, focus on the areas of T12 to L5, especially L1 to L3, the BP, sacrum, and atlas. Hot flashes, This is typically on the hormonal side. And the L1, T12, L1, L2 area are the direct innervation to ovaries and hormone balance, and possibly atlas. Painful menses is a structural problem. Has to do with lowest lumbar, spondylos, ilium subluxations, and sacrum subluxations. Cramps, again, another structural issue, focusing in on the lower lumbar spine, the ilium, and the sacrum. And difficult childbirth, actual delivery process, ASIN ilium is a very tough subluxation during delivery. We need to make sure that the pelvis is subluxation free, because this structural misalignment puts a lot of strain on the ligaments and does not allow the pelvis to open up the birth canal during delivery and can create complications. Another picture here of the nervous system and the innervation to the female reproductive system. Just a reminder again that the innervation to the ovaries comes from much higher in the lumbar spine, typically around L1, and that there are very many levels of innervation to the reproductive system, both the vaginal area and the uterus. So chiropractic care during a woman's life in general, but in particular during pregnancy, very, very important to keep that pelvis in line because of the massive amount of input it has to the reproductive system. The Webster technique. Many of you may be familiar with the Webster technique. Over the decades of the Webster technique, it's had a variety of different names, but it has been most recently called the Webster technique for liability purposes. It took out the words of breech turning technique or in utero restraint technique. It's just been narrowed down to a much more simpler Webster technique. And the Webster technique is defined as a specific chiropractic sacral analysis and diversified adjustment. The goal of the adjustment is to reduce the effects of sacral subluxation and SI joint dysfunction. In doing so, neurobiomechanical function of the pelvis is facilitated. And that's the best way to describe it. It describes basically subluxation in kind of layman's terms there. And what we do as chiropractors, neurobiomechanical, to restore function and facilitate, proper pelvis function. It relaxes the ligaments supporting the uterus, especially the round ligament, helps relieve pubic pain, and facilitates the positioning of the fetus by correcting neurological and Facilitates positioning of the fetus by correcting neurological and biomechanical function to the mother. This is a very valuable technique that you can use in your office with your pregnant patients. What we see here is an excellent diagram of the pregnant mom and the uterus, especially the ligament structure surrounding and supporting the uterus. You can see down here is the round ligament connected from the mid area of the uterus down towards the pubic bone. You could also see the ligament attachments to the sacrum here. This is why the Webster technique is invaluable for you as a chiropractor and your pregnant moms, because we try to keep the spine, biomechanics, as well as the neurological system balanced in this area. So not only do we have an effect on the nervous system, but we have effect mechanically on the support of the uterus, which is vitally important for baby positioning and proper delivery. Switching gears here. Not everyone's going to come to your practice because of their pregnancy, unless they've had a great referral or heard some good information about pregnancy and chiropractic care. But there will be many, many more people that come to your office because of pain. They often associate pain or back pain or even headaches with chiropractic care. That's a good thing, because with migraine headaches, chiropractors usually do very well. Migraine headaches, as described by Dr. Gonstead through the case management notes, is a body chemistry problem. Also, women are 4 times more likely to get them than men, and many of them, 65%, come from the malfunctioning thyroid area. This is C6 through T3, and in practice, probably 80 to 90% of the patients I cared for with migraine headaches, this was the region of the primary subluxation, and correcting this area had the best effect on the headaches. The second most common area is in the T12 to L3 segments. This region is more hormone related, hormone balance for both males and females. The T12 through L3 area for females and males are innervation to the reproductive system, and particularly the gonads, ovaries for the female and testicles for the male, and those are the ones that are body chemistry related to hormones. Women often get their migraine headaches either a couple days before or after their menses, and then they can easily relate the body chemistry or hormone imbalance to the migraines. Dr. Gonstead says it's a sympathetic problem, never adjusting the parasympathetic area above C5, sacrum, or ilium. Some important things to track during your care of a patient with migraines. It's important to track the progress of the headache with the chiropractic care. 3 things we want the patient to track for the migraine headaches. And when they do this, I want the patient to do this by charting the following. I want them to chart the frequency, the intensity, and the duration of the headaches. For the frequency, I want to know how often they get these headaches. I want them to try to tell me what precipitated the headache. Was there a specific trigger? Was it food or drink? Was it menses? Was it stress? Was it lack of sleep, medication, environment, etc.? We need to try to track down if there's a trigger for the headache. Oftentimes, if it's around a woman's menses, we kind of know what that is. That's the hormone imbalance giving them the migraine. And I had a patient who only got his migraines on Saturday mornings. Make the long story really short, Friday nights he would go out dancing with his wife, and they would have wine every Friday evening, and Saturday morning he'd have the migraines. We tracked it down to it being the red wine. It's the only time he drank the wine, and he had a reaction to the red wine, or perhaps the sulfates in the wine, and that's what it was. But he had C7 subluxations when he came in. I would adjust him, and by the end of the day, his migraines are gone. But we finally tracked down a pattern to the migraines, determined it was the red wine, and he basically was able to avoid his migraines almost exclusively by avoiding the wine. The intensity, we want them to give us their intensity, obviously on a scale of 1 to 10, with 10 being the worst. So we can then track this. It's all for documentation. And the other thing is duration. We want to know how long the headache lasts. We also want to know, how did it subside? Did they just take rest, sleep, turn off the lights, put their head on the desk, go to sleep? Did they exercise to get rid of it? Did they take medication, or did it self-resolve? This is also important to understand, how long it lasts, because when I'm caring for a patient with migraines, we sometimes see perhaps the frequency diminish first. Instead of getting it 3 times a week, it may go down to 1 or 2 times a week. The intensity usually lessens in the duration. I had a patient who was the wife of an entire family who were also my patients, but when the family was under care, originally the mom refused to get adjusted. She just didn't think she could stand having her neck popped, as she would say. She didn't like the noise. When she'd see me adjust her family and they made an audible noise in the cervical spine, she would just sit in the corner of the room and cringe. But she believed in the care and what it was good for, but just couldn't stand the cracking or popping, as she would say. Until one day she walked into my office. I hadn't seen her or the family in a while. She walks into the office and she goes, "I don't care what you do to me. Nothing can be worse than what's going on now." I said, "What's going on?" She goes, "I have migraine headaches." I get them 2 to 3 times a week. I'm on 2 medications, one preventive medication and one that I take in the onset of the headache. At least that many times a week, I am either have to go home from work, turn off the lights in my office, and put my head on my desk till the headache goes away, and I have to take my medications. And so whatever you do to me can't be worse than what I have going on now. I said, "Great, good." So let's do a workup. I remember working her up very well, and it was a C7 subluxation, and it was a big subluxation. How do I describe a big subluxation? She had a lot of tenderness and edema around the C7 area, a very significant scope reading, a lot of tenderness, and a great amount of fixation there. So this was a subluxation just screaming at us at C7. So I began adjusting her, and the adjustments went very well. A lot of movement on each of the few first adjustments, with a lot of audible, a lot of physical movement in the segment. And I adjust her twice one week, and she comes back the next week and she goes, I'm feeling pretty good. By the end of the second week, she goes, I'm feeling really good. And by the time we got to the third week, she goes, I leave my house and I don't even worry about having my medication. Because before, if I left my medication at home, my fear of getting the headache was so bad, I would go back home and get my medication. I would never leave home without it. So she was doing really, really well. Her headaches basically subsided within 3 weeks, and that was probably 4, maybe 5 adjustments at the most. And another thing happened that was really interesting. She goes, yeah, my husband brought something to my attention the other day. I said, what is that? She goes, well, oftentimes when I eat, I gag on my food. I have a very hyper-reflexive gag reflex. And she goes, that's gone away. I don't have it anymore. I said, that's interesting. I said, because the same nerves that come out of the area that I've been adjusting not only can go and help you with headaches, typically thyroid again, it also are some of the innervation to the throat area. So by correcting the nerve pressure in the brachial plexus, which goes to the thyroid gland, as well as the muscles for your gag reflex, we were able to eliminate that. We didn't even know it was an issue, but it resolved. Okay? And I can honestly say every patient that's been into my office for migraine care has seen a reduction in frequency, intensity, and duration, and in most cases, all three. And in some cases, we've been able to eliminate the headaches altogether. So when a person comes into my office for migraines, I know it's going to be a good case, and I know for a fact I'll be able to help them. How much do you think the case management information presented today can benefit you in practice? You can rate it on a scale of 1 to 5. During the entire quarter, we have gone through a variety of different types of cases and how Gonstead Chiropractic manages them. We went through acute lower back, we went through facet syndrome, we went through spondylolisthesis, we discussed some things to do with cervical spine, we went through some protocols for cervical injuries. We also went through some pediatric care, and we talked about some indications and contraindications for high velocity adjusting as we do in Gonstead. But the Gonstead system has a vast, vast amount of management for all different types of issues in the nervous system. And in this course, we only got to cover just a fraction of them, but hopefully gave you a little bit of insight into Gonstead Chiropractic, how we adjust, why we adjust the way we do, and how and why we manage particular cases the way we do. So hopefully you guys had a great quarter. I know it's been a challenging one with our new online protocols here. I wish you all good luck in your finals. It was a great quarter. I liked having you guys here. I will see you guys soon when I present this lecture to you. And if you don't listen to this lecture till right before finals, good luck on your finals. Take care.